welcome to the Deep Dive. Today we're plunging headfirst into a corner of the medical world that's often overlooked but is absolutely fundamental to mastering our understanding of human health.
Definitely. It's a fascinating area.
We're embarking on a comprehensive deep dive into fungal infections, specifically those less common systemic mycoses and superficial mycoses, all meticulously outlined in Chapter 219 of our comprehensive source material.
Right. And Chapter 219 gives us a really solid framework for these specific groups.
Exactly. Now, while this chapter hones in on these fascinating challenges, it's just one piece of the puzzle, right? Our source also touches upon other significant fungal threats like mucormycosis and pneumocystis infections in other sections.
Showing us just how vast this landscape of fungal pathogens truly is. It's huge.
It really is. So, our mission today is to take you beyond just a basic understanding. We're aiming for true mastery to help you grasp these concepts like the elite professionals in the field.
Extracting those crucial insights, the surprising facts, and importantly, the clinical relevance that truly matters.
Yes. So if you're ready to unravel the mysteries of the fungi that cause unique challenges, understand how they manifest, and learn what it truly takes to fight them, then this deep dive is absolutely for you.
And what's truly fascinating here is how these organisms, many of which are just common inhabitants of our environment, can suddenly transform into significant threats.
Especially for certain people, right?
Exactly, especially for vulnerable populations. This deep dive will hopefully illuminate the intricate, often complex interplay between the fungus itself, the host's immune system, and the subtle environmental conditions that allow these infections to take hold and progress.
It's that triangle fungus host environment.
Precisely. We're going to explore the entire spectrum today, from those, deeply invasive systemic infections that can spread throughout the body and threaten lives, to those incredibly common but often misunderstood infections that largely remain on the skin, hair, and nails.
Yeah, the ones people might actually encounter more often.
Right. And understanding these less common infections is paramount because their clinical presentations can be incredibly tricky. They often mimic other, more familiar conditions.
Making diagnosis tough.
Very tough. And early, accurate diagnosis is often the critical factor that dictates patient outcomes. It can literally be the difference between successful, timely treatment and, prolonged illness, or worse.
The stakes are indeed incredibly high when you consider those nuances. Now, before we jump into specific diseases, our source material highlights a core characteristic many of these fungi share: dimorphism. That sounds technical, but important.
It is. It's a fantastic foundational concept.
So what exactly does it mean for a fungus to be dimorphic? It sounds kind of like a superpower.
Hey, you could sort of think of it that way. Fungal dimorphism is indeed a key characteristic of many of the important fungal pathogens we'll encounter today. It directly influences how these organisms cause disease.
Okay.
Essentially, dimorphic fungi are biological chameleons. They're organisms that can exist in two distinct morphological forms.
Two shapes.
Exactly. And their switch between these shapes is largely dictated by environmental conditions, particularly temperature.
Temperature, okay.
Think of it this way. In their natural outdoor environmental niches, whether it's the soil, decaying vegetation, or even within certain plants, they typically exist as molds.
Like fuzzy stuff?
Yeah, filamentous structures. And these molds produce microscopic spores called conidia, which are their infectious forms. These conidia are tough, designed for environmental survival, and can easily become airborne.
Waiting to be breathed in or get into a cut.
Precisely. But here's where their adaptability becomes critical for human health. Once these conidia are inhaled or introduced into mammalian tissues, which is a much warmer, nutrient-rich environment.
Our body temperature, basically.
Exactly. At temperatures generally above 35 degrees Celsius, very close to human body temperature, the mold form undergoes a remarkable transformation. It converts into the yeast form.
So it changes shape inside us.
It does. And this yeast form is the one that typically proliferates, spreads, and actually causes disease within the host's body. This remarkable ability to switch between a mold and a yeast form is a crucial virulence factor. It lets the fungus adapt and survive successfully in two vastly different environments: the outside world, where it spreads, and inside us, where it causes infection.
That makes sense. It needs different tools for different jobs.
Absolutely. And it's also worth noting that other significant endemic mycoses, things like histoplasmosis, coccidioidomycosis, and blastomycosis, which are discussed in other chapters of our source,
Right, the big endemic ones.
they also fall into this category of dimorphic fungi. This really underscores how pivotal this characteristic is for understanding a broad range of serious systemic fungal infections.
That adaptability, switching between mold and yeast depending on temperature, truly sounds like nature's brilliant survival mechanism. But I'm curious, does that mean these fungi are effectively cloaking themselves from our immune system in different environments? Or is it more about metabolic efficiency? Or perhaps both?
That's a great question because it's probably a combination of factors. The ability to switch forms definitely provides them with a survival advantage in different niches.
Okay.
As a mold, they're excellent at environmental dispersal and resisting the elements, like you said. As a yeast within the host, they often become more compact, maybe easier for phagocytic cells to engulf, but also their surface antigens might change.
Ah, making them harder for the immune system to spot.
Potentially, yes, or harder to clear effectively. It allows them to adapt to the host's defenses and resources, optimizing their growth and spread within the body.
Fascinating. So from understanding how these fungi adapt to the human body, let's turn to our first specific deep dive. Sporotrichosis. You might know it as rose gardener's disease,
That's the one.
which sounds almost charming until you realize it's about a fungal infection.
Yeah.
So if you've ever pricked your finger on a rose thorn, this next part might make you think twice about gardening gloves, or at least reach for some extra heavy-duty ones.
Hey, good advice.
Tell us, what's the etiologic agent here, and where do we typically encounter it?
You're right. The Rose Gardner's disease moniker captures a very common mode of transmission, but the full picture of sporotrichosis is much broader and more complex.
Okay.
The etiologic agent isn't just one species, it's actually a complex of 6 closely related organisms, collectively known as the Sporothrix schenckii complex,
A whole family of them.
pretty much. Of these, S. schenckii and S. brasiliensis are the specific species responsible for the vast majority of human infections.
Then where do they hang out?
These Sporothrix species are found worldwide, and their natural habitat is quite diverse. You'll commonly encounter them in sphagnum moss, a popular gardening material, but also in decaying vegetation and various types of soil. Because of this ubiquitous environmental presence, sporotrichosis most commonly affects individuals involved in outdoor activities that bring them into direct contact with these materials. Think landscapers, gardeners, tree farmers, even hobbyists.
Makes sense.
The primary way people get infected is through a localized infection of the skin and subcutaneous tissues following what we call traumatic inoculation of conidia. It simply means the fungus gets introduced into the body through a break in the skin, for example, from a thorn prick, a splinter, or a cut that's been contaminated with fungal spores.
Got it.
Now, a critically important and frankly surprising aspect of its epidemiology, especially in recent years, is direct transmission from infected animals to humans.
Animals, like what?
Cats, primarily. Our source highlights a large ongoing outbreak of sporotrichosis in Rio de Janeiro, Brazil, which has been directly linked to cats. Cats are incredibly susceptible to S. brasiliensis, and they can readily transmit the infection to humans, often through scratches or bites.
Wow, so cat scratches aren't always just scratches.
Exactly. This cat-to-human transmission is a significant public health concern in affected regions, turning beloved pets into a potential source of infection.
That's definitely something to be aware of.
And while localized skin infections are by far the most common, there are also less common but significantly more severe forms. We see osteoarticular sporotrichosis, which affects bones and joints, most often in middle-aged men who abuse alcohol.
Suggesting some kind of vulnerability there.
Right. Then there's pulmonary sporotrichosis affecting the lungs, occurring almost exclusively in individuals with chronic obstructive pulmonary disease, or COPD, who've inhaled the organism.
So breathing it in is another route.
Yes, especially for that specific group. And perhaps most concerning, widespread dissemination throughout the body occurs almost entirely in markedly immunocompromised patients, especially those with advanced AIDS.
So the immune system is key to keeping it contained.
Absolutely. It highlights how profoundly a patient's immune status dictates the severity and potential spread of the disease.
That makes the cat link particularly compelling, and something many might not realize. So if someone gets pricked by a thorn from contaminated soil, what might they actually see developing on their skin? And how does a clinician start to differentiate that from other similar-looking skin issues?
That's a great question because recognizing the typical clinical presentation is often the first crucial step for early suspicion. Days or even several weeks after that initial traumatic inoculation, say, a thorn prick, a small raised bump, a papule develops at the injury site.
Okay, a little bump.
This papule usually then ulcerates, forming an open sore. What's important to note, and a bit counterintuitive, is that this ulcer is generally not very painful.
Painful. That seems odd for an ulcer.
It does, doesn't it? And that can sometimes be misleading and delay a person seeking medical attention. But here's where it gets really interesting and characteristic for sporotrichosis.
Wow.
Similar lesions then begin to develop along the lymphatic channels that drain the area. This forms a chain of nodules and ulcers, creating the classic lymphocutaneous lesion. Think of it like beads on a string moving up the arm or leg.
Ah, following the lymph system. That's a big clue.
A very strong diagnostic clue. However, not everyone presents with this classic lymphatic spread. Some patients might develop what's called a fixed cutaneous lesion.
Meaning it just stays put.
Exactly. This lesion can appear verrucous, meaning wart-like or simply ulcerative, but it remains localized to the initial site of inoculation without extending along those lymphatic channels.
So it can look different ways.
It can. And for clinicians, the differential diagnosis is crucial. You have to distinguish lymphocutaneous sporotrichosis from several other conditions that can present in a remarkably similar fashion.
Like what? What are the main lookalikes?
The most important mimics to consider are nocardiosis, another bacterial infection that can cause similar skin and lymphatic lesions, and non-tuberculous mycobacterial infections, especially those caused by Mycobacterium marinum, which is also often associated with water-related injuries like cleaning fish tanks.
Okay.
You'd also consider leishmaniasis, a parasitic infection that can cause chronic skin lesions, particularly in certain endemic regions. The variability underscores why simply looking at a rash isn't enough. Proper testing is often needed.
Given how tricky some of those manifestations sound, especially with those lookalikes, how do clinicians definitively diagnose sporotrichosis, and what's the gold standard in the lab?
You're right, clinical suspicion is essential, but it's just the first step. The definitive diagnosis of sporotrichosis is most reliably established by culture.
Growing the fungus.
Exactly. Sporothrix shankinki usually grows readily as a mold when material collected from a cutaneous lesion, such as a biopsy of a nodule or a swab from an ulcer, is incubated on Sabouraud's agar at room temperature.
Sabouraud's agar, right? The classic fungal medium.
That's the one. This is the gold standard because it allows for the definitive isolation and precise identification of the specific fungal agent, differentiating it from all those mimics we mentioned.
Makes sense. What about looking at tissue samples?
Beyond culture, histopathologic examination of biopsy material can also provide important clues, although it's often not definitive on its own. When examined under a microscope, the tissue typically shows a mixed granulomatous and pyogenic reaction.
So inflammation trying to wall it off and fight it.
Kind of, yeah. Think of it as the body's immune cells trying to build walls around the infection, that's the granulomatous part, while also fighting it head-on with pus and acute inflammation, the pyogenic part.
Okay.
In some cases, tiny oval or cigar-shaped yeasts, which are the forms of sporothrix found in human tissue, can sometimes be seen with special stains like PAS or Gamori methenamine silver.
Cigar-shaped. That's distinctive.
It is, but these yeasts can often be sparse and difficult to find, meaning a negative histopathology doesn't rule out the infection.
Ah, so culture is really key.
Culture remains the ultimate gold standard for confirmation. So while histopathology can support the clinical suspicion, culturing the organism remains imperative for a precise and confident diagnosis.
And once diagnosed, what's the path to recovery and what are the challenges, especially for those with more severe forms? It sounds like it could be a long road, particularly if you're dealing with a disseminated form.
Indeed, the treatment regimen and overall prognosis vary quite significantly based on the specific form and severity of sporotrichosis. Fortunately, for the most common presentations, cutaneous and lymphocutaneous sporotrichosis, the prognosis is generally excellent.
That's good news.
Our source references the Infectious Diseases Society of America, or IDSA, guidelines, which are incredibly important for guiding clinical practice. The first-line therapy for these localized infections is itraconazole, typically at a dosage of 200 milligrams per day.
And how long do you take it?
Treatment's continued until about 2 to 4 weeks after all the lesions have visibly resolved, which usually means a total course of anywhere from 3 to 6 months.
So several months.
Yes, it takes time. But the success rate for this approach is remarkably high, often reported between 90% and 100%.
That's very effective. Are there alternatives?
There are. Fluconazole is available, but is noted to be less effective than itraconazole for spore trichosis. Interestingly, voriconazole is specifically stated as not effective for spore trichosis.
Oh, important distinction.
Crucial distinction, yes, given its broad spectrum against other fungi. Posaconazole has shown successful use in a small number of patients, offering another option in complex cases.
Okay. What about older treatments?
Right. Now, here's a key insight regarding treatment choices. There's still the saturated solution of potassium iodide, or SSKI.
Potassium iodide, really?
Yes. This agent is still used primarily because it's much lower in cost compared to the newer azoles like atraconazole, making it an attractive option in resource-limited settings.
The cost factor.
But the trade-off is huge. SSKI is often poorly tolerated by patients due to various adverse reactions, including a persistent metallic taste, uncomfortable salivary gland swelling, a generalized rash, and fever.
Doesn't sound pleasant.
Not at all. So, while cost-effective, patient compliance with SSTI can be a significant challenge, highlighting that sometimes the best treatment isn't just about killing the bug, but what a patient can actually tolerate over months.
Good point. Any other options?
High-dose terbinafine may also be effective for lymphocutaneous infection, adding another possibility.
Okay. What about the more severe forms, like in the lungs or bones?
For the more severe forms, such as pulmonary and osteoarticular spore trichosis, the treatment duration is significantly longer. Patients typically require itraconazole at a higher dose, 200 milligrams twice daily, for a full 12 months.
A whole year.
Yes. And if the pulmonary disease is particularly severe, or if the infection is disseminated, meaning it has spread widely throughout the body, including involvement of the central nervous system, initial treatment with amphotericin B or AMB is required.
The heavy hitter.
Exactly. Specifically, a lipid formulation of Ambiri, typically at 3 to 5 milligram per kilogram daily, is used, with a higher dose often necessary if the CNS is involved. After a period of initial clinical improvement, maybe 4 to 6 weeks, therapy is then switched to oral itraconazole, again for a prolonged period, usually 200 milligrams twice daily for at least 12 months.
So a long course even after the initial IV treatment.
A very long course. A particularly challenging situation arises in patients with AIDS. For them, lifelong suppressive therapy with itraconazole 200 milligrams per day is often required.
Lifelong. Wow.
Often, yes. This continuous therapy is typically maintained until their CD4 plus T cell count is reliably greater than 200 cells per microliter for at least 12 months, indicating a more robust immune recovery.
But the overall outlook for severe forms.
Unfortunately, the challenge with these severe and disseminated forms is that they respond relatively poorly to antifungal therapy overall, even with the most potent agents. It underscores the severity and the inherent difficulty in managing these advanced infections effectively.
That makes the prognosis for severe forms quite concerning, even with treatment. And the cost-benefit analysis for SSKI is a powerful insight. Now let's shift our focus geographically, moving south to explore Mycoses, another fascinating dimorphic fungus, but one that presents a unique regional enigma, largely contained to specific parts of Central and South America.
That's right. Mycoses, or PCM, truly is a fascinating regional enigma.
So what's the story behind this fungus and its unique epidemiology?
The etiologic agents are Paracoccidioides basiliensis and the less frequently reported Paracoccidioides lutzi. These are, as we previously discussed, thermally dimorphic fungi.
Changing shape with temperature again?
Exactly. They are primarily found in humid, tropical, and subtropical areas of Central and South America, with a particularly high prevalence in Brazil. Their presence is strongly linked to the specific soil and climate conditions there.
And the epidemiology, you said, is unique.
What's quite striking is the significant male-to-female ratio. It's been reported to vary widely, from 14.1 to as high as 70.1 in various studies. 70 to 1. That's huge. Why?
It's a notable characteristic. It's often attributed to occupational exposures and possibly hormonal factors. There's some evidence suggesting estrogens might offer some protection.
Interesting.
The disease predominantly affects older men, especially those who work as farmers or are involved in other agricultural activities, strongly suggesting an occupational exposure link to the environment.
So farmers breathing it in from the soil.
That's the thinking.
Uh-huh.
Acquisition occurs after the inhalation of aerosolized conidia from the environment. People become infected by breathing in the fungal spores present in disturbed soil or air.
Okay, but you mentioned an enigma.
Right. Here's where the enigma aspect truly emerges and presents a major clinical challenge. For most patients, the disease rarely develops at the time of the initial infection. Instead, it appears years, sometimes even decades later.
Decades later.
How? This long latency period strongly suggests that the disease develops presumably after the reactivation of a latent infection, much like tuberculosis can reactivate years after initial exposure if the immune system becomes compromised. So it just hangs out dormant.
Exactly. Individuals can carry the fungus silently for a very long time before clinical disease manifests, often when their immune status changes due to age, concurrent illness, or other factors that trigger reactivation.
That long latency period is indeed fascinating and presents a unique challenge for diagnosis. So, what are the two main ways this disease presents clinically, and what should clinicians be looking for to suspect it, especially given that long wait time?
Given the varied immune status and age of affected individuals, paracoccidioidomycosis typically presents as one of two major syndromes.
Okay, what's the first one?
The first is the acute or juvenile form. This presentation is uncommon and primarily affects persons under 30 years old or immunocompromised individuals of any age.
Younger people or those with weak immune systems?
Right. It manifests predominantly as a rapidly progressive disseminated infection involving the reticuloendothelial system. Think of this as the body's widespread network of immune cleanup crew spleen, liver, lymph nodes.
So it spreads quickly through the immune system itself.
Exactly. When the fungus gets into the system, it means it's really spreading throughout the body's major defensive hubs, leading to rapid, widespread disease. This form can be particularly aggressive in immunocompromised patients.
Okay, and the second form?
The second, and far more common, is the chronic or adult form, which accounts for approximately 90% of all cases. This form predominantly affects older men, aligning perfectly with the epidemiology we discussed.
The farmers, right.
Mostly, yes. The primary manifestations of this chronic form include progressive pulmonary disease, which mainly affects the lower lobes of the lungs and can lead to significant fibrosis, permanent scarring, and hardening of lung tissue.
Lung scarring.
And alongside the pulmonary involvement, patients often develop ulcerative and nodular mucocutaneous lesions. These lesions are particularly prevalent in the mucous membranes of the upper respiratory tract, such as the mouth, nose, throat, and even the skin of the face.
Mouth and nose sores.
Yes, and they can look quite nasty. For clinicians, differentiating these mucocutaneous lesions is absolutely crucial. They must be distinguished from other conditions that cause similar oral or facial lesions, such as leishmaniasis, which is another endemic parasitic infection in some of these regions.
Yeah.
And very importantly, from squamous cell carcinoma, a type of skin cancer. The distinction can be incredibly challenging without proper diagnostic tools.
So high suspicion needed in those areas.
Exactly, especially in the demographic most commonly affected by the chronic form.
How is such a regionally specific and often latent infection definitively diagnosed, particularly when considering its various forms? And what's the key visual clue in the lab that screams paracoccidioids?
Right, the definitive diagnosis, the gold standard, is established by the growth of the mold form of P. brasiliensis in culture at room temperature.
Culture again. But that takes time.
It does take time, weeks sometimes, which isn't ideal when a patient needs rapid treatment, so a quicker, albeit presumptive diagnosis can often be made directly from clinical specimens. This presumptive diagnosis relies on the detection of the distinctive thick-walled yeast forms of the fungus in purulent material, like pus or in tissue biopsies.
And what's distinctive about them?
What makes these yeasts particularly characteristic and a crucial visual clue is their unique budding pattern. They have multiple narrow-necked buds attached circumferentially. This appearance is famously described as resembling a ship's wheel or a Mickey Mouse head.
Ship's wheel. Okay, that's memorable.
It really is. It makes it quite recognizable under the microscope for experienced professionals.
So why is seeing those specific budding patterns so critical for a presumptive diagnosis?
It's critical because it provides an immediate, strong indicator of paracoccidioids infection, allowing clinicians to initiate empiric treatment much faster than waiting for culture results. This rapid presumptive identification is invaluable in endemic areas where quick intervention can significantly impact patient outcomes.
So it buys crucial time.
Exactly. So while culture is needed for definitive confirmation and species identification, the microscopic finding of these characteristic yeast cells is a powerful and very specific diagnostic tool in the right clinical context.
That distinctive microscopic appearance sounds like a powerful and somewhat whimsical clue for clinicians in the field. And once identified, what's the recommended treatment? And how does the prognosis vary for patients with this unique infection, especially considering the long-term impact on the lungs?
Once paracoccidioidomycosis is identified, the prognosis for patients generally is quite good with appropriate therapy. Itraconazole is considered the drug of choice for the treatment of this infection.
Itraconazole again. Seems like a workhorse.
It is for many of these endemic mycoses. It's typically prescribed at a dosage of 100 to 200 milligrams per day for a prolonged period, usually between 6 to 12 months.
6 to 12 months, that's a commitment.
It is. This extended course is necessary to ensure eradication of the fungus and prevent relapse, given its propensity for latency.
Right, that long dormancy period.
Exactly. Several alternatives are available if itraconazole isn't suitable or effective. These include voriconazole and posaconazole, also typically for 6 to 12 months.
Okay.
Another option is trimethoprim sulfamethoxazole, or TMP-SMX, but for a much longer duration, ranging from 12 to 36 months.
Up to 3 years, wow.
Yeah. And while TMP-SMX is the least costly of these agents, it historically has a slower response rate and a higher rate of relapse, making it a less preferred option if the newer azoles are available and tolerable.
Got it. What about really sick patients?
For seriously ill patients, especially those presenting with severe or rapidly progressive disease, initial treatment with amphotericin B or AMB is highly recommended.
Back to MB.
Yes, either the deoxycholic form or a lipid formulation. Once the patient shows significant clinical improvement and is stable, the therapy is then typically switched to oral itraconazole, usually 200 milligrams twice daily, for 12 months to complete the prolonged treatment course.
So a step-down approach.
Exactly. Overall, patients with paracoccidioidomycosis have an excellent response to antifungal therapy, which is very encouraging.
But there's always a but, isn't there?
Well, yes. A significant long-term issue, particularly for those with the chronic form of the disease that affects the lungs, is that pulmonary fibrosis can be progressive despite successful treatment of the fungal infection itself.
Meaning the lung scarring gets worse even after the fungus is gone.
That's right. Even after the fungus is cleared and the infection is cured, the lung damage and scarring can continue to worsen, leading to long-term respiratory complications and a diminished quality of life.
That's a critical point about the potential for progressive fibrosis even after the infection is cured, showing us that cure doesn't always mean a return to baseline. Now let's journey further east to talaromycosis, an infection endemic to Southeast Asia with a unique link to local wildlife. What makes Talaromyces marnefae such a specific and concerning pathogen in this region?
Talaromycosis, caused by Talaromyces marnefae, which interestingly was formerly known as Penicillium marnefae.
Related to penicillin, like penicillin.
In the same broad group, yes, but very different in terms of causing disease. T. marnefae is indeed geographically restricted and has some truly unique epidemiological features. It is a thermally dimorphic fungus.
Mold outside, yeast inside.
You got it. And it's specifically endemic in the soil in certain areas of Vietnam, Thailand, and other southeastern Asian countries. Its presence is strongly tied to the specific environment of that region.
And the wildlife link.
What makes its epidemiology particularly intriguing is its peculiar link to bamboo rats. These rodents are known to be naturally infected with the fungus, although they rarely show any signs of disease themselves. They essentially act as carriers.
So the rats carry it but don't get sick.
Often, yes. Most human cases occur in persons living in rural areas where these bamboo rats are found, strongly suggesting an environmental connection mediated by the rat's activities. However, it's crucial to clarify that there is no evidence for direct rat-to-human transmission.
Ah, so you don't get it from the rat directly.
Correct. Instead, it's believed that humans acquire the infection by inhaling conidia, or spores, directly from the contaminated environment, likely from soil disturbed by these animals.
Okay. Who gets this infection typically?
A pivotal aspect of talaromycosis, distinguishing it from some of the other systemic mycoses, is host susceptibility. Infection is exceedingly rare in immunocompetent hosts.
So healthy people usually don't get it.
Right. The vast majority of cases are reported in individuals with advanced AIDS. This makes Mycoses a classic opportunistic infection, serving as a strong indicator of a severely compromised immune system.
Like a marker for advanced AIDS in that region.
Exactly. Once inhaled, the organism converts to its yeast phase in the lungs, similar to other dimorphic fungi, and then spreads hematogenously via the bloodstream throughout the reticuloendothelial system, impacting various organs like the spleen, liver, and lymph nodes.
Since this primarily affects severely immunocompromised individuals, especially those with advanced AIDS, how does it present clinically? And are there any telltale signs that can help differentiate it from other infections, especially given its mimicry is something like histoplasmosis?
You're absolutely right. The clinical manifestations of Mycoses can be quite deceptive because they frequently mimic those of disseminated histoplasmosis, another serious systemic fungal infection that often affects immunocompromised individuals.
So similar symptoms.
Very similar, often non-specific symptoms. Patients commonly present with persistent fever, profound fatigue, significant weight loss, and dyspnea, which is difficulty breathing. Additionally, signs of systemic involvement often include lymphadenopathy, swollen lymph nodes, and hepatosplenomegaly, enlargement of the liver and spleen.
That sounds like a lot of infections, really.
It does. These symptoms alone are very nonspecific and wouldn't immediately point to Mycoses. However, here's a key detail that can help differentiate it and serve as a crucial diagnostic clue.
The telltale sign.
The presence of distinctive skin lesions. These skin lesions appear as papules, small raised bumps that crucially often umbilicate.
Umbilicate, like a belly button.
Exactly. They have a central depression or dimple, giving them a striking resemblance to molluscum contagiosum, a common viral skin infection.
Ah, okay, that specific look.
Yes. While other disseminated infections might cause various skin lesions, the specific appearance of these umbilicated papules in a patient from an endemic region with a compromised immune system is a highly suggestive feature that can guide clinicians toward the correct diagnosis. This particular skin manifestation is often the aha moment.
That distinctive umbilicated skin lesion sounds like a critical piece of the diagnostic puzzle, given its similarity to other disseminated infections and the specificity of its endemic region. How do we definitively confirm a diagnosis of Mycoses, and what should the lab be looking for?
The definitive diagnosis of Mycoses is primarily established by culture of Myces marniferae from clinical specimens. This can be from blood or from biopsy samples of affected tissues such as skin, bone marrow, or lymph nodes.
Growing it again.
Yes. The organism usually grows relatively quickly, within about a week, when cultured on standard fungal media. What's particularly distinctive and incredibly helpful in the laboratory is that T. marniferae grows as a mold that produces a unique and very striking diffusible red pigment that seeps into the agar.
A red pigment. That sounds cool.
It's quite remarkable and serves as an important visual identifier in the lab, allowing for a strong presumptive identification even before further microscopic confirmation.
So the lab tech sees red, thinks Mycoses.
It's a big crew, yes. Beyond culture, histopathologic examination of tissues and smears from blood or skin lesions can also provide a quick presumptive diagnosis. Under the microscope, clinicians or pathologists will observe oval or elliptical yeast-like organisms with central septation.
Septation, like a line across the middle.
Exactly, an internal dividing wall within the yeast form. This is a very distinguishing morphological feature for T. marniferae in tissue, setting it apart from other yeast forms. So while the red pigment in culture is a key identifier, seeing those centrally septated yeast forms in a biopsy can rapidly guide the diagnostic process.
And for treatment, what are the options? And what's the outlook for patients, especially considering its alarmingly high mortality rate if left untreated?
The treatment for Mycoses is quite specific and depends on the severity of the infection. For mild or moderate infections, itraconazole is considered the drug of choice.
Itraconazole again.
Yes, it's typically prescribed at 200 milligrams twice daily for a period of 12 weeks. Voriconazole can also be used as an alternative option for these less severe cases.
Okay, but severe cases.
For severe infections, which are unfortunately common in the immunocompromised population this fungus targets, the initial treatment requires much more aggressive therapy, usually with amphotericin B.
Amb needed up front.
Yes, either a lipid formulation or amine deoxygolate. Amb is continued until significant clinical improvement occurs, after which therapy is typically transitioned to oral itraconazole, again at 200 milligrams twice daily for 12 weeks, to complete the treatment course.
That two-phase approach again.
Common for many severe systemic fungal infections. A critical aspect of managing mycosis, especially in patients with AIDS, is the absolute necessity for maintenance or suppressive therapy.
Keeping it from coming back.
Exactly. These patients are recommended to continue itraconazole at 200 milligrams per day until their CD4 plus T cell count has been consistently greater than 100 cells per microliter for at least 6 months. This suppressive therapy is vital to prevent relapse.
And the prognosis overall.
The prognosis for mycosis is stark. Disseminated mycosis is usually fatal if not treated. The prompt initiation of appropriate antifungal therapy is absolutely life-saving.
But with treatment.
With effective treatment, the mortality rate significantly drops to approximately 10%. This dramatically highlights the importance of early diagnosis and aggressive, sustained antifungal therapy. It's a prime example of how timely medical intervention can utterly transform patient outcomes.
That dramatic improvement in mortality with treatment really underscores the critical importance of quick diagnosis and intervention. Next, we're diving into the phaeohyphomycosis, a broad and somewhat intimidating category named for the distinctive dark pigmentation of the fungi involved. What exactly defines these infections, and why is that dark pigmentation, that pheo part, so important?
The phaeohyphomycoses represent a diverse group of infections, all caused by what are called demaciaceous or brown-black fungi.
Demaciaceous means dark-colored.
Essentially, yes. The defining characteristic here, as you mentioned, is their inherent dark pigmentation. This dark color is due to the presence of melanin within their hyphae and conidia, the fungal filaments and spores.
Melanin, like in our skin.
Exactly, the same pigment, but in the fungus. The term phaeohyphomycosis itself is a broad descriptive term used to encompass any infection caused by a pigmented mold.
Okay, any dark mold infection.
Right. This broad definition includes some specific and important syndromes, notably eumycetoma and chromoblast mycosis, as well as a range of other infections affecting various parts of the body.
Got it.
It's an important distinction that while phaeohyphomycoses are always caused by these dark pigmented molds, eumycetomas themselves can actually be caused by hyaline molds, which are non-pigmented, as well as brown-black molds.
Oh, so eumycetoma isn't always caused by a dark mold.
Correct. Furthermore, only about half of all mycetomas are actually due to fungi. The other half are caused by actinomycetes, which are bacteria that can beautifully mimic fungal infections clinically.
Bacteria mimicking fungi.
Okay.
Tricky.
Very tricky. So the presence of pigmentation in the fungus is key to defining a phaeohyphomycosis, but the clinical syndrome might have broader causes. Most of these demaciaceous fungi typically cause localized subcutaneous infections, usually after direct inoculation, like a cut or a puncture wound.
Like sporothrix.
Similar entry route, yes. However, in immunocompromised patients, or if the inoculation is particularly deep, they can also cause disseminated infections and very serious focal visceral infections, impacting internal organs like the brain or lungs, and that melanin they produce.
Yeah.
It's not just for color, it's considered a key virulence factor for all pigmented molds, actively contributing to their ability to cause disease and potentially making them more resistant to the host's immune defenses and even some antifungal agents.
So the melanin itself helps them cause trouble.
It seems to play a role, yes.
So we're talking about a wide variety of pigmented culprits. How do these diverse fungi typically make their way into the body, causing such varied presentations, from a skin lesion to a brain infection?
You're right, a large number of pigmented molds are capable of causing human infection, reflecting their ubiquitous presence in the environment. Most of these fungi are found naturally in soil or on plants, and some are even known to cause significant plant diseases.
Everywhere.
Pretty much. Among the more common genera reported to cause human infection are Alternaria, Exophiala, Curvularia, and Wangiella species. A particularly notorious real-world example highlighted in our source involved Exurohilum species.
Oh yeah, the outbreak.
The big one in the United States in 2012. This outbreak caused severe and tragically fatal central nervous system infections following the injection of methylprednisolone that had been contaminated with this fungus.
Contaminated injections. Terrifying.
It starkly demonstrates how direct injection can completely bypass normal defenses and lead to devastating systemic disease.
Okay. What about the specific syndromes, eumycetoma and chromoblastomycosis?
Right. For those specific syndromes, Madarella species are the most common cause of eumycetoma, while Fonsesia, Cladophillophora, Pheolophora, and Rhinocladiella species are the most common culprits for chromoblastomycosis.
How do people get those?
The routes of acquisition are diverse. Traumatic inoculation into the eye or through the skin is very common, but infection can also occur through inhalation, or as seen in that outbreak, by injection of contaminated medication. As one mentioned, melanin is a key virulence factor.
Right.
Furthermore, some species, specifically Cladophilophora bantiana and Reina cladiella mackenzie, are particularly noteworthy because they are neurotropic.
Meaning they like the nervous system.
Exactly, they have a predilection for the nervous system and are more likely to cause dangerous CNS infections. In immunocompromised patients, or when these pigmented molds are directly injected into deep structures, they become true opportunists. They exhibit angioinvasion.
Invading blood vessels.
Right, and can mimic other well-known opportunistic infections like aspergillosis, making their diagnosis and management incredibly challenging. Eumycetoma and chromoblastomycosis specifically are acquired by inoculation through the skin and are seen almost entirely in tropical and subtropical areas, predominantly affecting rural laborers who have frequent exposure.
With such varied entry points and such a wide array of fungi, what are the clinical signs we need to watch for, particularly highlighting the two main syndromes, eumycetoma and chromoblastomycosis? The differences seem subtle, but incredibly important for a proper diagnosis.
Indeed, the clinical manifestations of pheohyphomycosis are remarkably varied. Generally, dematiaceous molds are a common cause of allergic fungal sinusitis and a less common but more serious cause of invasive fungal sinusitis. Keratitis, inflammation of the cornea, can occur following traumatic corneal inoculation. In immunocompromised patients, while some may develop only localized nodular lesions at the entry site, others can develop severe systemic infections, including pneumonia, dangerous brain abscesses, or widespread disseminated infection. The exerohyalum outbreak we mentioned showed the worst outcomes: meningitis, basilar stroke, epidural abscess, vertebral osteomyelitis, arachnoiditis, all devastating CNS conditions.
Truly awful. Now, the two main chronic ones, eumycetoma first.
Right. Eumycetoma is a chronic subcutaneous and cutaneous infection that typically endures on the lower extremities, often the foot. Its key characteristics are swelling of the affected area, the development of sinus tracts, which are channels that drain to the skin surface, and crucially, the appearance of visible grains or fungal colonies that are discharged from these sinus tracts.
Grains coming out of the skin.
Yes, visible fungal colonies. It's an indolent and disfiguring disease progressing slowly over years, and critically, it involves adjacent fascia and bony structures, sometimes leading to horrific deformities. This deep invasion leads to complications like fractures of infected bone and bacterial superinfection.
Okay, that sounds destructive. How is chromoblastomycosis different?
Chromoblastomycosis, by contrast, is also an indolent subcutaneous infection, predominantly affecting the lower extremities. It's characterized by nodular, verrucous, wart-like, or plaque-like painless lesions that grow slowly over months to years.
So also slow growing, but
The key difference here, which is crucial for differentiation from eumycetoma, is that chromoblastomycosis hardly ever extends to adjacent structures like bone or deep fascia.
so it stays more superficial, relatively speaking.
Relatively, yes. While less invasive, long-term consequences can include bacterial superinfection and chronic lymphedema. And rarely, these chronic lesions can even develop into squamous cell carcinoma, a type of skin cancer.
Still serious long-term risks.
Definitely. But the presence of draining sinuses, grains, and deep bone involvement truly differentiates eumycetoma as a much more destructive, invasive process.
The variety of presentations is remarkable, and those specific differentiating features between eumycetoma and chromoblastomycosis are incredibly invaluable for clinicians. How do we definitively diagnose these infections, especially given the visual similarities and the broad range of potential culprits?
The specific diagnosis of any infection with a pigmented mold, or phaeohyphomycosis, is definitively established by the growth of the organism in culture. This is absolutely essential.
Why so essential here?
Because, as we discussed, these brown-black molds need to be differentiated from hyaline molds, such as Aspergillus or Fusarium, which cause clinically similar invasive infections but often require different treatment approaches. Culturing the organism allows for precise identification and susceptibility testing.
Okay, how about for mycetoma specifically?
For mycetoma, a tentative clinical diagnosis can often be made when a patient presents with the classic triad of swelling, sinus tracts, and the discharge of grains. However, confirmation requires further steps. Histopathologic examination of tissue and culture are necessary to confirm that the etiologic agent is indeed a mold and not an actinomycete.
Right, the bacterial mimic.
Exactly. Which requires antibacterial treatment, not antifungals. So that distinction is critical.
And for chromoblastomycosis.
In the case of chromoblastomycosis, the diagnosis primarily rests on the histologic demonstration of sclerotic bodies in the affected tissues.
Sclerotic bodies.
These are distinctive structures. They are dark brown, thick-walled, septate fungal forms that famously resemble large yeasts or copper pennies under the microscope. Seeing these specific structures is highly characteristic.
Copper pennies, another visual clue.
Yes. Once these sclerotic bodies are identified, culture is then performed to establish which specific pigmented mold is causing the infection.
Are there faster methods coming?
Advanced diagnostic tools like PCR assays are increasingly being used, offering more rapid and precise identification. However, these are typically available only through specialized fungal reference laboratories, not quite routine yet.
And finally, what are the treatment approaches for these challenging, often chronic infections, and what's the prognosis like, especially for the more severe forms like a CNS infection?
Treatment and prognosis for pheohyphomycosis are highly variable and often quite challenging. For disseminated and focal visceral infections caused by brown-black molds, the choice of antifungal agent is complex. It's based on factors like location, extent, in vitro susceptibility testing if available, which isn't always standardized for these rare molds in clinical experience.
What drugs are typically used?
Amphotericin B is unfortunately not effective against many of these organisms, though it works for some. Itraconazole, voriconazole, or posaconazole are often used for more localized infections. When infections involve the central nervous system, voriconazole is generally preferred because it gets into the brain well.
And for disseminated disease?
Both voriconazole and posaconazole are viable options, as they are available in both intravenous and well-absorbed oral formulations. Despite these options, disseminated and focal visceral infections, particularly those involving the CNS, are associated with alarmingly high mortality rates.
Really difficult to treat successfully.
Extremely difficult. For the more localized chronic subcutaneous infections like eumycetoma and chromoblastomycosis, treatment typically involves a combination of medical therapy and surgical removal.
Surgery plus drugs.
Often, yes. Surgical excision is most effective if it can be performed before the infection has spread extensively. For chromoblastomycosis specifically, cryosurgery, freezing, and laser therapy have also been used with variable success.
And the drugs for those?
In terms of medical therapy, pneumocystoma has been treated with itraconazole, voriconazole, posaconazole, and less commonly, terbinafine, all with variable rates of success. For chromoblastomycosis, itraconazole, terbinafine, and flucytosine have been used, again with variable success.
Variable success sounds not great.
It reflects the reality. The overall prognosis for both chromoblastomycosis and eumycetoma is that they are chronic, indolent infections that are exceptionally difficult to cure. Moreover, the prolonged and often multi-drug antifungal treatment required can be prohibitively expensive.
A huge challenge, especially where these are common.
Absolutely. A significant challenge, especially in the tropical and subtropical regions where these diseases are most prevalent and resources may be limited.
The long-term and often costly nature of those treatments really underscores the global health challenge these infections pose, particularly in developing nations. Now let's shift to a group of fungal infections that are especially concerning for those with weakened immune systems, the opportunistic fungi. Our source highlights 3 genera of hyaline molds, Fusarium, Cedosporium, and Lomentospora, and one yeast-like genus, Trichosporon. What makes them opportunistic, and why are they so dangerous, particularly for these vulnerable hosts?
That's a crucial shift in our discussion, as these organisms pose a very different kind of threat. When we talk about opportunistic fungi, we're referring to organisms that are generally benign or cause only mild localized infections in individuals with healthy, intact immune systems.
So they don't bother most people.
Right. They might be ubiquitous in the environment or even part of our normal body flora. However, they become prominent and dangerous pathogens in immunocompromised patients, those with weakened defenses due to cancer, chemotherapy, organ transplantation, HIV/AIDS, etc.
They seize the opportunity.
Exactly. Their name truly reflects their nature. The genera you mentioned, Fusarium, Cedosporium, and Lomentospora, are all hyaline, meaning non-pigmented molds. When they cause invasive infections in immunocompromised hosts, their clinical manifestations and even their histopathologic appearance often mimic aspergillosis.
Another common opportunist mold. So they look alike.
They look very similar, both clinically and under the microscope. This mimicry makes diagnosis incredibly challenging because the presentation isn't unique. The yeast-like genus Trichosporon also falls into this category.
Okay.
In immunocompetent hosts, these fungi might cause only localized infections of skin or nails, more of an annoyance. But in immunocompromised patients, their role shifts dramatically to causing widespread, life-threatening invasive disease. What makes them so dangerous in this setting is their ability to become angioinvasive.
Invading blood vessels again.
Yes, invading and destroying blood vessels. Think of the fungus using the body's circulatory system like a highway to spread quickly. This allows them to disseminate rapidly, causing multifocal infections and extensive organ damage, leading to high mortality rates if not aggressively treated.
That concept of angioinvasion really helps explain the rapid and widespread damage. Let's start with fusariosis. What exactly is fusarium? And how does it typically infect vulnerable individuals, given its apparent omnipresence in our environment?
Fusarium species are incredibly ubiquitous fungi, found worldwide in soil, on plants, and even in water. This means exposure is almost unavoidable.
So we encounter it all the time.
Pretty much. While they can cause localized infections in healthy individuals, they have truly emerged as major opportunists in markedly immunocompromised patients. The primary route of human infection is often through the inhalation of conidia, or spores, from the environment.
Breathing it in.
Yes, especially when construction or environmental disruption stirs up dust. However, infection can also result from ingestion of contaminated food or water, or crucially, direct inoculation through a break in the skin, like a wound or a medical device insertion site.
Like catheters.
Potentially, yes. A significant and memorable example of direct inoculation leading to a large outbreak was the severe Fusarium keratitis outbreak among soft contact lens wearers in 2005-2006.
Oh, I remember that. Contact lens solution.
Exactly. It was traced back to a specific brand of contact lens solution that had become contaminated with the mold, leading to serious, sight-threatening eye infections.
Scary. Who's most at risk for the really bad disseminated form?
Disseminated fusariosis, the most severe form, is reported most often in patients who have a hematologic malignancy like leukemia, are profoundly neutropenic, meaning dangerously low white blood cell counts,
Neutropenic, right.
have recently received a hematopoietic cell transplant or a solid organ transplant, or have severe burn wounds. These are all conditions that severely compromise the immune system, essentially opening the door for fusarium.
So once fusarium takes hold in these profoundly immunocompromised patients, what are the clinical manifestations? And is there a key distinguishing feature that can help clinicians differentiate it from other similar infections like aspergillosis, which you mentioned it mimics?
In immunocompetent persons, fusarium species typically cause localized infections. They are a common cause of fungal keratitis, that severe eye infection we mentioned, which can cause vision loss. They can also cause onychomycosis, fungal nail infection.
Nail fungus.
Right, often just a cosmetic annoyance in healthy people. But critically, in neutropenic patients, onychomycosis due to fusarium can be a dangerous source of subsequent hematogenous dissemination.
The nail infection can spread to the blood.
Yes, the fungus from the nail can enter the bloodstream and spread throughout the body. So in these vulnerable patients, a seemingly minor nail infection should be aggressively sought and treated.
Good point. What about in the really immunocompromised?
In profoundly immunocompromised patients, the disease is much, much more severe. Fusariosis becomes angioinvasive, and its clinical manifestations strikingly mimic those of aspergillosis. In the lungs, it typically causes multiple nodular lesions. Sinus infections are common and likely to invade adjacent structures.
Okay, so similar to aspergillus so far. What's the key difference?
Disseminated fusariosis occurs primarily in neutropenic patients with blood cancers and transplant recipients. Here's the key differentiating feature, a diagnostic clue worth remembering. Skin lesions are extremely common with fusariosis.
Skin lesions. What kind?
These lesions are typically nodular or necrotic, appearing as bumps or areas of dead tissue, and they are usually painful. Crucially, they appear over time in different locations, seemingly popping up in new spots.
Painful spreading skin lesions.
Exactly. This widespread, painful, and often necrotic skin involvement is a strong indicator for fusariosis in a neutropenic patient and can guide the clinician toward the correct diagnosis where other invasive mold infections might otherwise be suspected.
That's a super helpful diagnostic clue, those painful necrotic skin lesions appearing in different spots. Given its mimicry of aspergillosis in other areas, how is a definitive diagnosis of fusariosis made, and what are the unique challenges and opportunities in identifying it in the lab?
The diagnostic approach for fusariosis typically involves two key components for confirmation. First, documentation of the growth of fusarium species from involved tissue in a culture.
Culture again.
And second, demonstration of invasion by histopathologic techniques showing septate hyphae in tissues. We need to see the fungus and see it invading.
But you said it looks like Aspergillus in tissue.
That's the significant challenge. Fusarium species are incredibly difficult to differentiate morphologically from Aspergillus species in tissue biopsies, both present as septate hyphae. Therefore, identification with culture is absolutely imperative. Growing it allows precise identification, which is crucial for guiding treatment, as their antifungal susceptibility profiles can differ significantly.
Okay, so culture is vital. Is there anything else that helps?
Yes, an extremely helpful diagnostic clue that often sets fusariosis apart is its unusual ability to grow in blood cultures.
It grows in blood. That's unusual for molds, right?
Highly unusual for molds like Aspergillus. Blood cultures are positive in as many as 50% of patients with disseminated fusariosis. This positive blood culture can be a critical piece of evidence pointing toward fusarium, especially in a febrile neutropenic patient with compatible signs, allowing for quicker targeted therapy.
A positive blood culture for mold should make you think fusarium.
Strongly, yes. It's an important early warning signal.
And once fusariosis is identified, what's the recommended treatment and what's the outlook for these often severely ill patients, especially considering its historic and frankly terrifying high mortality rate?
The treatment of fusariosis is notoriously challenging because fusarium species are often resistant to many antifungal agents.
Resistance is a big
A
problem.
huge problem. Currently, the recommended first-line therapies include a lipid formulation of amphotericin B, voriconazole, or posaconazole. These are the most potent systemic options.
Okay.
Given the variability and susceptibility among different fusarium strains in the often dire clinical situation, many physicians opt for a combination approach, especially for initial therapy. They frequently use both a lipid formulation of amphotericin B and either voriconazole or posaconazole.
Hedging their bets with two drugs.
Essentially, yes, because susceptibility information isn't standardized and doesn't always predict clinical response. By using two agents with different mechanisms, they aim to maximize the chances of success. When using either voriconazole or posaconazole, serum drug levels should be closely monitored.
To make sure they're working and not toxic.
Exactly. Historically, mortality rates for disseminated fusariosis have been alarmingly high, up to 85%. While improved therapies have led to a decrease, they still hover around 50%.
Still 50%. That's grim.
It is. And a critical factor determining prognosis is the patient's immune status. If neutropenia persists, meaning their neutrophil count does not recover, the mortality rate for fusariosis approaches 100%.
Wow. So immune recovery is absolutely essential.
Absolutely essential. It highlights the necessity of immune recovery, often through neutrophil transfusions or growth factors, in conjunction with antifungal therapy for a favorable outcome. It's truly a race against time.
That truly highlights the dire nature of persistent neutropenia in these infections, a sobering reminder of the immune system's power.
These next two, Cedosporium and especially Lamentosperor prolificans, sound intimidating. Lamentosperor prolificans in particular sounds like one of the toughest fungal infections to treat. What do we need to know about these pathogens? You've hit on a critical point. These are indeed formidable pathogens, and understanding their distinct characteristics, especially their resistance, is vital. The two main agents are the Cedosporium apiospermum complex and Lamentospora prolificans, which used to be called Cedosporium prolificans.
Okay, a name change there.
Yes. While the S. apiospermum complex is more frequently reported, both are major pathogens, particularly in immunocompromised hosts, where they can cause severe pneumonia, disseminated infection, and devastating brain abscesses.
Where do they come from?
Environmentally, organisms of the S. apiospermum complex are found worldwide in temperate climates, often associated with water sources like tidal flats, swamps, ponds, and also in manure and soil. L. prolificans is also in soil, but has a more geographically restricted distribution, often linked to warmer climates.
And how do people get infected?
The primary route of infection is predominantly through the inhalation of Canidia, the spores. However, direct inoculation through the skin or into the eye can also occur.
Inhalation again.
Primarily, yes. These fungi are aggressive opportunists, and their ubiquitous presence means constant exposure risk for vulnerable populations.
And how do these infections typically manifest clinically in both immunocompetent and immunocompromised individuals, and how might their presentation subtly differ from something like fusariosis?
The clinical manifestations vary significantly based on the host's immune status, much like fusarium. In immunocompetent persons, Cedosporium and Lamentaspora species are a prominent cause of eumycetoma.
The chronic foot infection with grains.
Right. They can also cause severe keratitis, the eye infection, often from accidental corneal inoculation.
Okay, but in the immunocompromised.
The real danger emerges there. In patients with hematologic malignancies, especially leukemia with neutropenia, transplant recipients, and those on high-dose steroids, these organisms are highly angioinvasive. They cause severe pneumonia and widespread dissemination. The pulmonary infection often mimics aspergillosis.
Mimics aspergillus again. How does it differ from fusariosis clinically?
A point of distinction from fusariosis is that while skin lesions can occur with cedosporiosis and lamentasporiosis, they are not as common or as consistently painful as those seen with fusariosis.
Fewer or less painful skin lesions. A subtle clue.
A subtle but potentially valuable clinical clue, yes. It can help guide appropriate diagnostic steps.
Given how aggressively these fungi can behave and their mimicry of other mold infections, how is a definitive diagnosis made for cedosporiosis and lamentasporiosis? And what are the crucial considerations for the lab to pinpoint these elusive pathogens?
Diagnosis depends on two key elements. First, the growth of Cedosporium or Lamentaspora species from involved tissue and culture. Second, the histologic demonstration of septate hyphae invading tissues.
You need both culture and proof of invasion.
Both are absolutely essential. Culture evidence is essential because, like fusarium, these molds are notoriously difficult to differentiate from aspergillus in tissues based solely on microscopic appearance. Only culture can identify the specific genus and species.
And the invasion part.
Demonstration of tissue invasion is essential because these are ubiquitous environmental molds. They can sometimes be mere contaminants or colonizers. Finding the fungus and seeing clear evidence of its invasion is critical for confirming a true active infection.
Do they grow in blood cultures like fusarium?
There's a difference. Lamentaspora prolificans can grow in blood cultures, similar to fusarium, providing a potential early clue. However, Cedosporium apiospermum usually does not, making diagnosis of disseminated S. apiospermum more reliant on getting tissue biopsies.
And what about treatment and prognosis for these highly aggressive and often resistant pathogens? That sounds like a significant challenge given their unique resistance profiles.
You've hit on the core challenge. Treatment and prognosis are indeed very difficult, primarily due to their formidable resistance profiles. Both Cedosporium and Lamentaspora species are notoriously resistant to amphotericin B.
Resistant to AMB. That's bad.
Very bad, as it's a cornerstone drug. They're also resistant to echinocandins and some azoles. This significantly limits therapeutic options.
So what works for Cedosporium apiospermum?
For infections caused by S. apiospermum, voriconazole is generally considered the agent of choice. Posaconazole can also be used. The outlook remains serious, with mortality rates around 50%, even with treatment.
And Lamentaspora prolificans, you said it was particularly tough.
The situation is even more dire with Lamentaspora prolificans. This species is remarkably resistant. It is resistant in vitro to almost every available antifungal agent.
Resistant to everything, how do you treat it?
It poses an immense therapeutic dilemma. There's no single go-to drug. Given this extensive resistance, combination regimens have been attempted, for example, adding agents like terbinafine to a voriconazole regimen based on in vitro data suggesting possible synergy.
Trying combinations, hoping for synergy.
Exactly. It's often a desperate measure. Despite these aggressive approaches, the mortality rates for invasive L. prolificans infection remain exceptionally high, often reaching a shocking 85% to 100%.
85 to 100% mortality. Good grief.
It truly highlights the dire, almost untreatable nature of L. prolificans infection and the urgent need for new antifungal agents or entirely novel treatment strategies.
That's a sobering prognosis, truly. Finally, in our opportunistic section, trichosporonosis. This one sounds like it might have some unique characteristics beyond just being an opportunistic yeast. What are they, and why is it important to recognize this pathogen?
Trichosporonosis is caused by species within the Trichosporon genus, While many species cause relatively benign localized infections of hair and nails, the major pathogen responsible for severe invasive infection is Trichosporin asahi.
Okay, T. asahi.
This organism is classified as yeast-like. While it grows as typical yeast-like colonies in vitro, in the host's body, in vivo, it can present with a fascinating and distinctive mixture of morphological forms, including true hyphae, pseudohyphae, arthrochonidia, and yeast forms.
So it can look like different things under the microscope.
Yes, this pleomorphism, the ability to take on multiple shapes in tissue, is quite distinctive and helpful for diagnosis. Trichosporin species are commonly found in the environment, soil, sewage, water. They can rarely colonize human skin in the GI tract without causing disease.
So usually harmless residents?
Usually. However, similar to the other opportunists, systemic infection occurs almost exclusively in immunocompromised hosts. Hematologic malignancies, neutropenia, transplants, glucocorticoids, the usual risk factors.
And how does it get in?
The vast majority of systemic infections follow either inhalation or, very commonly, entry via central venous catheters,
Catheter infections again?
making it a significant bloodstream infection in hospitalized vulnerable patients. It's a reminder that even common environmental fungi can turn deadly given the right opportunity.
So if an immunocompromised patient develops trichosporinosis, how does it typically present clinically? And are there any specific symptoms or signs that stand out from other generalized infections?
The clinical presentation of disseminated trichosporinosis often resembles invasive candidiasis, another very common opportunistic yeast infection.
Mimics candida.
Yes. The initial manifestation is often fungemia, the fungus in the bloodstream, which can quickly lead to persistent fever and sepsis. Beyond fungemia, common manifestations include severe pneumonia and the development of characteristic skin lesions.
Skin lesions again, like fusarium.
A similar but maybe slightly different progression. These skin lesions typically begin as papules or nodules surrounded by redness and then critically progress to central necrosis. The center dies and turns black. This progression can be an important clue.
Okay. Anything else?
Additionally, a chronic form can occur, which mimics hepatosplenic candidiasis, involving persistent fever, abdominal pain, and often microabscesses in the liver and spleen. So, while it shares similarities with candidiasis, specific features like the necrotic skin lesions help narrow the differential.
Given its ability to mimic other yeast infections, how is a definitive diagnosis of systemic trichosporinosis established? And what's a surprising diagnostic clue that might arise from standard lab tests that clinicians need to be aware of?
The definitive diagnosis is established, as with many invasive fungal infections, by growth of the organism from involved tissues or from blood. Culturing from a sterile site confirms its presence.
Okay, culture first.
However, there's a fascinating and extremely helpful diagnostic clue for an early presumptive diagnosis. Histopathologic examination of a skin lesion, if one is present, showing that mixture of yeast forms, arthrochonidia, and hyphae is highly suggestive.
Seeing all those different shapes together.
Exactly, that combination is quite characteristic for trichosporon. But here's the super interesting aha moment, a real diagnostic pearl.
Ooh, okay.
The serum cryptococcal antigen latex agglutination test may surprisingly be positive in patients with disseminated trichosporinosis.
The cryptoantigen test, but it's not Cryptococcus.
Exactly. It's not Cryptococcus neoformans infection. It's because T. asahi and Cryptococcus neoformans actually share polysaccharide antigens. This cross-reactivity means a test for one fungus might pick up another, providing an unexpected but incredibly valuable diagnostic alert.
Wow, that's wild. A false positive that's actually a true clue.
Precisely. It prompts further investigation specifically for trichosporon. It's a prime example of how indirect clues can be so powerful.
That antigen cross-reactivity is a truly surprising and insightful diagnostic pearl. It's like a secret handshake between fungi. And finally, for trichosporinosis, what's the recommended treatment and what's the prognosis like, especially given the challenges with severe immunosuppression?
Treatment has been historically quite challenging. Rates of response to amphotericin B have been disappointing, and many trichosporon isolates are resistant to it in vitro.
So Ambi isn't great here either.
Often not the best choice. Instead, voriconazole has emerged as the antifungal agent of choice for systemic trichosporinosis. Posaconazole is also a viable option.
Voriconazole seems key for several of these tougher ones.
It has been a game changer for this infection. Historically, mortality rates for disseminated trichosporon infection were as high as 70%. With the more widespread use of voriconazole, these rates are fortunately decreasing.
That's hopeful.
It is. However, a critical determinant of prognosis remains the patient's underlying immune status. Patients who remain profoundly neutropenic are unfortunately highly likely to succumb to this infection, despite receiving appropriate antifungal therapy.
Back to the importance of immune recovery.
It underscores that crucial theme again. While antifungals fight the organism, a sustained recovery of the host's immune system is often paramount for ultimate survival.
That's a vital reminder about the host's role in fighting these complex infections. Finally, let's turn our attention to the fungal infections many of us are more familiar with, even if we don't always realize their fungal nature: the superficial cutaneous infections. Unlike the deep dives we've just taken into systemic threats, these fungi typically don't invade deeper tissues. So what defines this common category, and why are they such a prevalent part of human health?
You're absolutely right. These are the fungi that most people have likely encountered or at least heard about. Superficial cutaneous infections are broadly defined as fungal infections of the skin and skin structures, hair follicles, nails caused by molds and yeasts that do not invade deeper tissues.
They stay on the surface.
Exactly. They cause disease merely by inhabiting and proliferating within the most superficial keratinized layers of the skin, hair, and nails. They live on the surface, essentially eating the keratin protein. These agents are, in fact, the most common fungal infections of humans worldwide.
Why so common?
Their prevalence is high because the fungi that cause them are often ubiquitous in our environment or are even part of our normal skin flora, just waiting for the right conditions to overgrow. While incredibly common, the good news is that they only rarely cause serious infections or pose a direct threat to life.
So mostly annoying, not deadly.
Generally, yes. Their impact is usually localized, causing discomfort, cosmetic issues, or sometimes providing a portal of entry for secondary bacterial infections.
Let's start with yeast infections, specifically those caused by Mycoses. Many people might know this one by its common names like dandruff or tinea versicolor. What's its story, and how does it cause those widespread skin conditions?
You're exactly right. Mycoses species are the culprits behind those incredibly common conditions. What's truly fascinating about Mycoses is that it's a normal, harmless part of the indigenous human microbiota.
It lives on us normally.
It does. It's a regular resident of our skin, particularly found in the stratum corneum, the outermost layer-on areas like the back, chest, scalp, and face. These are typically areas rich in sebaceous glands, which produce sebum, an oily substance.
It likes oily skin.
Critically so. This lipid-rich environment is absolutely crucial for Mycoses as these organisms are lipid-dependent. They literally require external lipids or fats for their growth. Without those oils, they can't thrive.
Lipid-dependent, okay. How does it cause problems then?
The mechanism of disease is straightforward. These organisms do not invade below the stratum corneum. They simply proliferate on the surface, consuming lipids. They generally elicit little to no inflammatory response from the host directly. Instead, the symptoms arise when they overgrow or undergo a morphological change, from yeast to hyphal form, often triggered by factors like humidity, sweating, or increased sebum production.
Just an overgrowth issue.
Mostly, yes. It's a delicate balance on the skin surface.
So what are the specific clinical conditions Mycoses triggers, and how do they manifest? Also, given that they rarely cause serious issues, is there any scenario where Mycoses can lead to a more severe systemic infection that clinicians really need to watch out for?
Mycoses species are responsible for several very common skin conditions. The most well-known is tinea versicolor, also called pityriasis versicolor.
The patchy skin discoloration.
Exactly. This presents as flat, round, scaly patches of skin that can be either hypopigmented lighter than the surrounding skin or hyperpigmented darker. These patches are typically found on the neck, chest, and upper arms. They are usually asymptomatic, though some people get mild itching.
How do you tell it apart from something like vitiligo?
A key differential is vitiligo, which also causes depigmented patches, but critically, unlike tinea versicolor, vitiligo is not scaly. If you see scales, it's generally not vitiligo.
Good tip. What else does Mycoses cause?
Another common condition is folliculitis, when Mycoses infects hair follicles, typically on the back and chest. This presents as itchy papules and pustules and often mimics bacterial folliculitis. Seborrheic dermatitis is also caused by Mycoses.
Dandruff.
Dandruff is the scalp form, yes, but it also manifests as erythematous, pruritic, scaly lesions in eyebrows, mustache area, nasolabial folds. This condition can be particularly severe in patients with advanced AIDS.
Okay, now the serious scenario. Can it get systemic?
While generally benign, there is a rare but critically severe form, fungemia and disseminated infection. This almost exclusively occurs in a very specific, vulnerable population. Premature neonates who are receiving parenteral lipid preparations through a central venous catheter.
Premature babies getting high V-fats. Why them?
In this unique scenario, the lipid-dependent Mycoses can thrive within the lipid emulsion in the catheter line, enter the bloodstream, and cause a serious systemic infection. The lipids they need are being delivered right to them.
Wow. The treatment itself fuels the infection.
It highlights an important, albeit rare, exception to their typically superficial nature.
That's a really unique and specific scenario for systemic infection, and the lipid dependence is such a defining characteristic.
Yeah.
How are Mycoses infections typically diagnosed, and what's that very unique requirement for culturing it if a systemic infection is suspected?
Most cases of Mycoses skin infections are diagnosed clinically just based on their characteristic appearance and distribution.
Just by looking.
Often, yes, especially for things like tinea versicolor or seborrheic dermatitis. If the diagnosis is in doubt, a quick and simple microscopic examination can confirm it. Collect scrapings, put them on a slide with potassium hydroxide, KOH, and look under the microscope.
What do you see?
You'll typically see a classic mixture of budding yeasts and short septate hyphae, often described as having a distinctive spaghetti and meatballs appearance.
Spaghetti and meatballs, another memorable visual.
Quite unique for Mycoses. Now, regarding culture, it's generally not needed for superficial infections. However, in those rare cases where a disseminated infection is suspected, particularly in those premature neonates,
Yeah.
culturing Mycoses requires a very unique modification to the standard laboratory medium. Because they are lipid-dependent, sterile olive oil must literally be added to the culture medium.
Add olive oil to the agar. Seriously.
Seriously. This provides the essential lipids the fungus needs to grow in vitro. This is a truly unique requirement, showcasing its unusual lipid dependence. Without that added lipid, the organism simply won't grow, leading to a false negative culture.
That lipid dependence and the need for olive oil in culture is a great, very specific detail that sticks with you. So, what's the typical treatment for these common skin infections? And what's the prognosis like for both the common, benign forms and the rare, severe systemic infections?
For the vast majority of Mycoses skin infections, topical therapy is highly effective. Creams, lotions, shampoos applied directly.
Like anti-dandruff shampoo.
Exactly. Common options include selenium sulfide shampoo, ketoconazole shampoo or cream, and terbinafine cream, usually applied for about 2 weeks. Other, more expensive creams are rarely needed. For seborrheic dermatitis, mild topical steroid creams are sometimes used too for inflammation.
What if it's really widespread?
If the skin disease is extensive, oral antifungal agents like itraconazole or fluconazole at 200 milligrams daily can be used for a shorter course, typically 5 to 7 days.
Okay. And the rare fungemia in babies.
For the rare but serious cases of fungemia in neonates, treatment involves a systemic antifungal, usually an amphotericin B formulation or an azole like voriconazole, plus prompt removal of the central venous catheter.
Get the source out.
Absolutely. And critically, discontinuance of parenteral lipid infusions is also essential to cut off their fuel source.
Makes sense. Prognosis overall.
The prognosis for Mycoses skin infections is excellent. They are benign and self-limited. However, a key point for patients is that recurrences are the rule. People often get repeat episodes, especially in warm, humid weather.
So it keeps coming back.
Often, yes. The outcome of systemic infection in premature neonates depends heavily on underlying conditions and prompt intervention, but most do well once the catheter is removed and lipids are stopped.
And finally, a group that causes what many of us commonly refer to as ringworm, the dermatophyte infections. This name is actually quite misleading. What are these moles and how do they cause those characteristic skin lesions, and why are they so incredibly prevalent globally?
Dermatophyte infections, commonly but misleadingly called ringworm, a name that causes endless confusion because, as you said, worms are not involved at all.
Right, no worms.
They're caused by a specific group of molds belonging to the genera Trichophyton, Microsporum, and Epidermophyton. These organisms are unique because, unlike Mycoses, they are not components of the normal skin microbiota. Instead, they are highly specialized fungi evolved to live exclusively on the keratinized structures skin, hair, nails.
They eat keratin.
Essentially, yes. That's why they are aptly termed dermatophytes, literally skin plants. These infections are exceedingly common worldwide.
How do they spread so easily?
Their prevalence is due to several factors. They can be transmitted directly person to person or indirectly by fomites, hairbrushes, towels, wet floors, and showers. Several species are also zoonotic, transmitted from cats and dogs to humans. Others are geophilic, spread from soil contact.
Lots of ways to get them. Why the ring shape?
The characteristic ring shape results from the organism's growth pattern. The fungi grow outward in a centrifugal pattern in the stratum corneum, while the central area often clears as the fungus moves on, creating that distinct ring-like appearance.
Okay, and we should call it Tina, right?
Right. Ringworm is confusing. The Latin term tina, meaning worm, historically describes the serpentine nature. It's more accurate to use tina, followed by the body part, tinea capitis, head, tinea capitis, foot, etc.
Got it. How do they affect hair and nails?
When hair shafts are invaded, the organisms can be found either within the shaft, making it brittle, or surrounding it. Nail invasion usually occurs through the lateral or superficial nail plates and then spreads.
And the itching and redness, is that the fungus invading?
A critical point. The symptoms, itching, redness, scaling, are caused by the inflammatory reaction elicited by fungal antigens, the immune system's response, not by actual tissue invasion into deeper layers. The fungi stay superficial, but the immune reaction causes the symptoms.
Interesting. So it's our reaction causing the problem. Yeah.
Largely, yes. Epidemiologically, dermatophyte infections are more common in males than females. Studies suggest progesterone might inhibit their growth.
That distinction that symptoms are due to inflammation rather than invasion is quite key.
Yeah.
So understanding their preferred habitats, what are the specific clinical manifestations for the various Tinea infections on different body parts? And what are some critical differential diagnoses for each that a clinician must consider?
Understanding the specific Tinea presentations is crucial. Let's run through them.
Okay, head first.
Tinea capitis, affecting the scalp, is most common in children 3 to 7 years old. You see well-demarcated scaly patches, broken off hairs, sometimes alopecia, needs differentiating from bacterial folliculitis or psoriasis.
Body.
Tinea corporis, ringworm of the body, well-demarcated, annular, itchy, scaly lesions with central clearing, must be differentiated from contact dermatitis, eczema, and psoriasis. Tinea cruis, jock itch, almost exclusively in men. Red, pustular rash in the perineum with a discrete scaly border, usually itchy. Importantly, it typically lacks the satellite lesions seen in candidiasis. Needs differentiating from intertriginous candidiasis, erythrasma, bacterial, and psoriasis.
Feet. Athlete's foot.
Tinea pedis, athlete's foot, more common among men. Often starts in toe web spaces, peeling, maceration, itching, then a scaly, itchy rash along sides and soles. Hyperkeratosis, thickened skin, of soles often happens chronically. Importantly, it's implicated in lower extremity cellulitis because bacteria can enter through skin cracks.
And nails.
Onychomycosis, nail fungus. Toenails more often than fingernails, often with tinea pedis. Nail becomes thickened, discolored, may crumble. Onycholysis, separation from nail bed, almost always occurs. More common in older adults, those with vascular disease, diabetes, trauma, needs differentiating from nail psoriasis.
Those distinct presentations and differential diagnoses are incredibly helpful for identifying these common conditions. How are these dermatophyte infections typically diagnosed? And what's the role of the lab when the clinical picture isn't completely clear?
Many dermatophyte infections are diagnosed clinically by appearance alone, especially by experienced clinicians.
If it looks like ringworm, it probably is.
Often, yes. But if the diagnosis is in doubt or presentation is atypical, microscopic confirmation is quick and effective. Take scrapings from the active edge of the lesion, add KOH, warm it, and look under the microscope for hyphae.
Seeing the fungal filaments confirms it.
Exactly. Seeing those branching hyphae confirms a dermatophyte infection. Cultures are indicated in specific situations, like suspected outbreaks or if the patient doesn't respond to initial therapy.
To check the species or resistance.
Right, or maybe rule out a misdiagnosis. But for routine cases, clinical look and a KOH prep are usually sufficient.
And finally, what are the recommended treatment approaches for these common but often persistent infections, especially for chronic issues like onychomycosis, which seem particularly stubborn?
Dermatophyte infections generally respond very well to topical therapy for skin infections. Creams, lotions, sprays. Lotions or sprays are easier for large or hairy areas. For Tinea cruis, keeping the area as dry as possible is also critical.
What if topical isn't enough?
For extensive skin lesions, or if topical therapy fails, Oral antifungals can hasten resolution. Oral itraconazole or terbinafine are common options. Between these two, terbinafine interacts with fewer drugs and is generally considered the first-line agent for systemic treatment due to safety and efficacy.
Okay, terbinafine first choice orally. What about nail fungus? That seems tough.
Onychomycosis presents a particular challenge because it generally does not respond to topical therapy alone due to poor drug penetration into the nail. Newer topical solutions like efinaconazole applied for up to a year have shown some benefit, but systemic agents are often necessary.
So oral meds for nails usually.
Usually needed for a cure, oral itraconazole and terbinafine are effective because they accumulate in the nail plate. The decision to use systemic agents is complex, though weighing nail involvement versus potential side effects, drug interactions, and cost. Treating for purely cosmetic reasons alone is generally discouraged.
Good point. Do these come back often?
Relapses are quite common. Tinea cruris and tinea pedis relapses are frequent. Patients should treat early with topical creams. Even with onychomycosis, despite prolonged oral therapy, relapses occur in 25% to 30% of cases. They are notoriously difficult to fully eradicate.
Wow, what an incredible deep dive into the hidden yet absolutely critical world of less common systemic and superficial fungal infections. We've literally covered everything, from the global reach of Sporothrix and its surprising link to cats, to the unique and deadly challenges of Lamentis prolificans, and even the libby-loving fungi hiding on your skin.
It's a huge range, isn't it? From common annoyances to life-threatening diseases.
The level of detail we've explored, truly understanding the pathogenesis, the subtle clinical distinctions, the diagnostic pearls like those copper pennies or ship's wheels, and the precise treatment protocols, truly gives you a professional level grasp of these complex topics.
Hopefully, yeah. The goal is always deeper understanding.
You now have a shortcut to being incredibly well-informed, equipped with specific facts and an understanding of the intricate interconnectedness of these diseases, all without needing to wade through dense textbooks yourself.
And if we connect this to the bigger picture, this deep dive profoundly underscores how critical a patient's immune status and specific environmental factors are in dictating the severity and management of fungal infections.
That came up again and again.
It really did. It also highlights the constant evolution in our understanding and treatment of these often challenging pathogens, from discovering new diagnostic clues like cross-reacting antigens to the ongoing urgent battle against antifungal resistance, especially with species like Lamatospora prolificans.
Which raises some big questions.
Absolutely. This raises an important question for all of us. As our global environment continues to change, impacting fungal distribution, and as more individuals worldwide become immunocompromised due to medical advances in aging populations, how might the epidemiology and prevalence of these very less common infections shift in the future? Could they become much more common?
A really important thought, something fascinating to mull over. With the powerful professional level knowledge you've gained today, how might you approach understanding the next seemingly niche medical topic you encounter, seeking out those surprising, fascinating details that truly bring it to life and make it stick?
Yeah, what's the next deep dive?
What surprising, perhaps even slightly alarming fact about fungi will you share with someone next? Thanks for joining us on this deep dive.
Thanks, everyone.
We'll catch you next time.